presentation is to know the prognostic value of ST segment deviation in lead AVR in ECG, specifically in acute myocardial infarction. Next slide. Okay, so basically the AVR lead in the ST segment is somehow neglected. We have a background for this, why we should evaluate the AVR segment. So ischemic heart disease is branded as a modern epidemic by the WHO, and even in India, the burden of cardiovascular disease, especially coronary disease, is very high. One of the Registrar General of India had reported that CAD led to 17% of the total death and 26% of the adult death between 2001 to 3, which has increased to 23% of total and 32% of the adult in 10 to 13. So it is an increasing trend of the CAD and ACS, and even with that, mortality is also high. WHO even and global burden of the disease studies also highlighted the increasing trend in the years of life lost and disability adjusted life years from CAD in India. Next slide. So now introduction. There is actually 12-lead ECG is a crucial tool in the diagnosis and risk stratification of ACS and CAD till today also. More in the country, even worldwide, the ECG is the most reliable diagnostic tool to diagnose the acute myocardial infarction. And during acute myocardial infarction, there is the leads in the ECG are important determinant factors to localize the site of the CAD according to the vector. Now, if we talk about the lead AVR, which explores the two myocardial region, which tells about the inferior and lateral apex and the basal interventricular septum. If the patient is having the inferior lateral apex, which produce the AVR segment ST depression because it is away from the lead. So tail vector will be the depressed. So the AVR will be depressed and it is opposite to the inferior lateral apex. If it is the basal interventricular septum is affected, ischemic, the AVR segment will be elevated with the transluminal ischemia. And opposite happens in the anterior leads, V1 to V6. The lead vector of the AVR is oriented approximately from the cardiac apex to the outflow tract of the RV. So next slide, please. So now, so we conducted the study, which is single-centered observational study, and it is a prospective study which was conducted in the only single center with the patients of acute myocardial infarction, which qualifies the definition of the acute MI. When a patient comes and we do the biomarker, specifically cardiac troponin, which is rise or fall in trend, with the at least one value is about the upper limit. With the following one of the criteria is matched. So patient has the symptoms of ischemia or ECG shows the STD changes or any development of pathological Q wave or imaging 2D echo shows the evidence of the loss of any viable myocardium or any regional washer wall abnormality or angiography shows the intracoronary thrombus. Next slide, please. A study was done for a duration of 15 months in New Delhi with the diagnosis of acute MI, and in this study, the patient, with their symptoms admitted within 12 hours of the chest pain, we had included all those patients in this study. Next slide. So exclusion criteria we kept in the mind about we excluded the patient of any previous ischemic heart disease like SEMI and SEMI, pre-existing ECG abnormalities like pre-excitation syndrome or any RBBB or LBBB pre-existing. Any patient with any valvular heart disease or patient comes after the 12 hours of the chest pain, or patient does, or if the didn't go under the coronary intervention, sample size we calculated from the state calci component of the EPIC info version 7.2.1. Next slide, please. Now, how did we enroll the patient? We took a history, as well as patient underwent the physical examination, did the echo, did the echocardiogram with the echocardiographic standard. We measured the EF, RWMA, and we looked for any valvular heart disease or not. And ultimately, patient went for the coronary intervention and as well as angioplasty whenever it is required. And we draw some variables. Some are variables are quantitative variables that we compared with the unpaired t-test and cross tabulation test. For qualitative variables were compared by the chi-square of Fisher's exact test, and we took out the value of p if it is less than 0.05, which was considered significant, and the software used was SP or SS. Next. Now result. Next. We draw some conclusion. Next, please. Next slide. Draw the conclusion when we did the echo and we compared the echo with the EF after the procedure. So we, according to LVEF, we grouped into the if the patient is less than 30% echo, if the echo EF is less between 30 to 40%, or 1 to 50%, or more than 50%, and we compared with the ST segment in AVR. So in the conclusion, the patients the group of the patient with the isoelectric ST segment, the more these people more had a EF over around the normal, like in 20 cases, and in 16 cases out of the 55 had a EF of 30 to 40%. It is just the correlation between the echo and the ST segment in AVR in acute MI patient. With the patient, the segment of ST elevation with in AVR with when we correlated with the EF, most of the patient had a EF of 30 to 40%, like 13 out of the 28. Nearly 50% of the patient had a ST segment elevation, and 11 patient of ST segment depression had a 41 to 50% EF out of 27 patients. Next, when we compared the ECG with the coronary angiogram. Next slide, please. Okay. Previous slide. Go to previous slide. Go to previous slide. With the out of 55 patients with the ST segment if isoelectric, and 19 patients of ST segment elevation had a LED occlusion out of 28 patients. While ST segment depressed patient have a more like the LCX occlusion. Next slide, please. When we did the echo in follow-up and we compared with the ST segment deviation group with the compared EF with the ST segment deviation in AVR on follow-up basis. So in patient of isoelectric segment in AVR had 6 patient had a LVF, 5 patient had a ST segment elevation, and 3 patient had a ST depression. It is just correlation, which was this statistically was not significant. Next slide, please. On follow-up, we did the follow-up at 1 month. During 1 month, 16 patients out of the total 19 patients had a VT in one patient, or some patients were out of follow-up or died before the 1 month follow-up. So out of 19, most of the patient had a ST elevation in late AVR, and some had a 16 patient had a ST depression in AVR. With this ST elevation or depression is the previous ECG when we correlated with the VT. Out of Though this data was clinically not significant, we come to know that the patient if having the ST elevation or depression in lead AVR at the presentation, at the acute MI presentation, they are more likely to have a complication like VT, LVF. So now when we compared with the mortality, total from 110 patients, 11 patients died, 5 was lost to follow, and ST segment depression was in 4 patients, elevation was in 3, and in isoelectric it was 4. So when we together data of elevation and depression, so ST deviation patient had more mortality than the isoelectric ST segment in lead AVR. So though it was clinically not significant. Now, from above is a total of 110 patients admitted and followed up for 1 month. That study population was split into group of ST isoelectric. Next slide, please. Next slide. Next slide. Yes. Two group of patients with the isoelectric ST segment in lead AVR when compared with the patient with the ST segment deviation in lead AVR. It was clinically not significant in my study. So some previous study had shown the prognostic value of AVR in acute MI, which was significant, which tells about some information about the prognosis of the patient in near future. When we took for a subgroup analysis, so we came to know the patient with the ST segment elevation and more LV dysfunction than the patient with the isoelectric ST patients. And MR was more seen in the patient with the ST segment deviation, and more specifically when the ST segment is elevated. MR is mostly mild to moderate. VT was more common in the patient with the ST segment depression, which we saw in the table. Though clinically it was some significance like 0.0045. This was the data was significant. Some patient had a more VT when the ST segment deviation in lead AVR. Next slide, please. Now, in our study, which we conducted in MI patient and grouped into the isoelectric ST segment and ST deviation, there is no prognostic significance found, but ST segment deviations also observed to have a great significance in predicting the damaged vessel, location of culprit vessel, and risk stratification. So, prior knowledge of the ST deviation status might provide the insight into the risk of the complication of post-plasty patient. So next slide. The limitation to our study is a very small sample size of group. Some patients have financial constraints, said they did not undergo the angiography. It was some, and it is a single-centered study. So some populations only, some patients only taken. So these are the limitations. Future direction is we definitely can take a large-scale prospective cohort study to identify the potential of lead AVR in detection of the diagnosis of different types of MI, which can help to understand the prognostic value of lead AVR in Indian population. So as a conclusion, there is no significance between the isoelectric ST and ST segment deviation in the patient regarding the further trend of the patient's post-plasty. But some information we took out that it is safe to say that determining a ST AVR deviation in ST segment can help foresee complications among the patients with the ST segment deviation during follow-up. So these are some references. Next slide, please. Next slide. These are some references for the study we took out, and we took a help from these articles. Next slide. Thank you. Thank you very much. So take-home message is AVR lead is neglected in acute MI scenario. We don't look into the AVR much carefully, but definitely for during acute situation, it may not helpful for other things, but at least we can diagnose the left main disease with ST segment elevation in AVR, even proximal LAD, it is elevated. There are some other differential diagnoses of the ST segment elevation in AVR, embolism, right-sided heart failure, but we are not going into this detail. But I would like to tell that we should look into the AVR lead carefully, which if any elevation or depression, it can predict the near future complication according for the acute MI patient, and we can prevent, or rather we can carefully call patient for frequent follow-up, and we can do some other tests to prevent the heart failure as well as ventricular tachycardia, VFib, and sudden cardiac death. Thank you very much for hearing me. I would like to.
From Perm City, Russia. I'm working in Perm State Medical University, named academician Evgeny Antonovich Wagner. And I want to share with you with a little fragment of my research work, which I spent time during last 6.5 years, many years. It is a clinical work, which I doing, completing, mostly myself with inspiration, of course, with inspiration. My work dedicated to investigation of features of target organs damage in people with chronic heart failure infected with HIV virus, depending on blood pressure control. And of course, it is a little fragment of my work in our university. In recent years, the life expectancy of people living with HIV infection has significantly risen. It is no secret that many different diseases of the cardiovascular system have been described in a patient with HIV infection. There are data on the prevalence of arterial hypertension among HIV-infected people in various countries, which range from 8% in Poland to 51% in Republic of South Africa, for example, and this percent are very different in different continents. I will demonstrate two persons. They are all very high in my research work. This is my respectable teacher, Professor Michael Zuberev. He is investigator of many new methods in cardiology. He has 2 educations in medical education and physical education. And he is also of new impedanceometry method in cardiology. Now it is successfully used in Japan. And my second inspiration, Professor Emmanuel Abiago. He living in Zimbabwe. And he interested in the same topic as me. And we collaborate with him very successfully now. Thank you, Emmanuel. Emmanuel today has a birthday. Happy birthday, dear Emmanuel. Wish you all the best, and the main is the health. HIV infection remains a pandemic with more than 37 million registered cases worldwide. The life expectancy of those has increased significantly. However, the high frequency of cardiovascular disease, including chronic heart failure and arterial hypertension. A lot of another diseases present, but today we will say about these 2. The aim of the study was to find the characteristic of target organs damage in patients with chronic heart failure infected with a human immunodeficiency virus, depending on blood pressure control in a single-stage clinical trial. In a multifunctional hospital, I myself observed 240 patient HIV infection. In a second level, inside this group was separate 160 patients with the signs of chronic heart failure. In a third level, inside this group was separated 40 patients, including arterial hypertension, chronic heart failure, and HIV infection. I want to say that myself, I'm a practitioner cardiologist, internal disease doctor, and ultrasound diagnostic. Myself, I'm doing echocardiography many years. That is why not difficult was to do this job alone. Inclusion criteria was present of HIV infection, present of chronic heart failure, which was estimated regarding the higher level of NT-proBNP in the plasma of peripheral blood, more than 125 picogram per milliliter, and present systolic and or maybe diastolic dysfunction of left ventricle in echocardiography, and clinical symptoms of chronic heart failure. Also, important criteria was stabilization of the condition of the diseases that becomes a reason for hospitalization. And many patients was with pneumonia, for example, with cholecystitis, with pancreatitis, different reasons. And important next moment of inclusion, it was a patient concern to participate in the study. It was patient who was not allowed to take part, was not agree to take part in this investigation. That is why they was not invited. Exclusion criteria was a lot. There are different malignant neoplasm, negative deviant behavior, acute coronary syndrome less than 3 months old, stroke or transient ischemic attack in the last 3 months, acute heart failure or acute decompensation of chronic heart failure was exclusion criteria too, and patient refusal to sign informed voluntary consent. And necessary to say that there was no any children and pregnancy women too. And here present the main top moments of materials and method was used that such kind of chemical reactives as NT-proBNP for immunoassay made in Russia vector-based. Cystatin C levels was the same company chemical reactives determining a serum of the blood. Also used China reactives, chemical reactives company Sanlong Biotech. For example, tissue metalloproteinase number 1 in serum was revealed with help of this company reactives. Also used Hungary equipment, tensiometer angiograph, 24. It is a special device which gives possibility to measure not only BP level, it gives possibility to measure indexes of arterial stiffness of aorta and brachial arteries. That is why it is very interesting for research. And also, I give a photo of ultrasound equipment which I used for echocardiography for all my patients. This is Vivit TH General Electric USA. It is equipment of a hospital where I was this investigation. A lot of data I got was printed in article in a Scopus journal about this work. The main I demonstrate today in this report. Clinical and echo events of arterial hypertension in HIF. You can see in compare with patient without arterial hypertension. Valvular disorders. What mean valvular disorders? Intensive regurgitation or valvular stenosis or possible infectional endocarditis in anamnesis, but not this hospitalization time. Another, thrombocytopenia. Thrombocytopenia reveals in patient with HIV and arterial hypertension more than in patient without arterial hypertension. In this research work, and in all my large this field of work, I accentuate attention that disorders of hemopoietic system, of bone marrow, is going parallel with the heart and kidney disorders in patients with HIV. That is one of the signs of bone marrow disorders, thrombocytopenia. Antiretrovirus therapy used less in patients with arterial hypertension than in patients without arterial hypertension, totally less used, but it was patients who took this therapy too. Diastolic dysfunction of left ventricle more often reveals in patients with arterial hypertension. Rise of left atrium volume present more often in patients with arterial hypertension. And higher myocardial muscle mass index was in patient with arterial hypertension, and estimation of left ventricle hypertrophy more often in this group too. And these features, of course, need accentuate attention in the figures. For example, in patient with elevated BP, in 87.9, almost 88%, was in a increase left atrium volume. It is a very intensive, differ significantly with a patient with normal BP. Left ventricle hypertrophy more often meet in patients with arterial hypertension, but it is regarding the disease. Of course, we understand that it is not a secret. Diastolic dysfunction of left ventricle more often meet in patients with arterial hypertension than without. Left ventricle ejection fraction was some high in patient with arterial hypertension, but it is due to the disease specificity. We understand why. And the main point: left ventricle diastolic dysfunction more often, left ventricular hypertrophy more often, and increase left atrial volume in patient with arterial hypertension, chronic heart failure, and HIV infection. It is some specificity. Of course, during the research work, during the time when I all measure, think about this result, I analyzed multiple indexes. A lot of indexes, more than 100 was analyzed. And on this table, I present for you main indexes laboratory, which may be more interesting regarding the arterial hypertension. And you can see the difference that tissue metalloproteinase 1 was more higher level in patients with arterial hypertension. What is tissue metalloproteinase 1? It is an indication, it is an index, laboratory index of fibrosis, laboratory index of fibrosis of arteries. That is why this index maybe will correlate with the stiffness of arteries. You will see it some later. I will demonstrate for you that it is really true. And also, we can see that more higher level of serum cystatin C was in a patient with arterial hypertension. Why is it happening? It happened due to the rise of event of chronic kidney disease in this group of patients, intensive glomerulopathy. And regarding this, we can see that decreased glomerular filtration rate significantly differ from the glomerular filtration rate in patients without arterial hypertension. Also, we can see different in serum iron. Yes, present troubles with the bone marrow, but totally serum iron level more higher in patient with arterial hypertension than in patient without arterial hypertension. Why is it happening? It happened due to many reasons. One of them, that it is a role of inflammatory process. Another interesting moment, it is the level of platelets. I demonstrate to you that thrombocytopenia present in patients with arterial hypertension. And here you can see that amount of platelets in usual blood analysis in this patient, quite less than in patient without arterial hypertension. Of course, it's necessary explain. From one reason, it happened due to thrombopoietin deficiency, but it is a little reason. The main reason, totally, of course, it is a bone marrow failure, which rising in patient with HIV infection. Today, my colleague Emmanuel Biago will say about it, will speak about this trouble too, about pancytopenia in patient with HIV infection, which is a really interesting topic. What about hemoglobin level? Of course, there are no quite clear difference, of course, But if you will see the median level, it is quite less in patients with arterial hypertension. Maybe need to observe some more patients, some more cases, and this difference will be clear. Maybe, but it is very expensive, of course. No any sponsors in my work. That is why we'll compare what I have. Arterial wall stiffness and vascular changes. Key observation. With help of tensiomet equipment from Hungary, I got possibility to measure augmentation indexes of aorta and brachial arteries. High augmentation index value in the aorta and brachial artery in patients with elevated blood pressure was revealed. Increased pulse wave velocity indicated growing arterial wall rigidity. Very important to measure augmentation indexes in patients in large vessels. It is easy to observe. It's possible compare with echocardiographic figures. It's possible compare with biochemical data. For example, in my work was a comparative analysis of level of augmentation indexes and tissue metalloproteinase 1 as a biomarker of fibrosis. Elevated tissue metalloproteinase 1 level correlate with fibrotic changes in the heart and vessels, confirming instrumental diagnostic data. This is a marker reflecting vascular remodeling and stiffness in HIV-infected patients with chronic heart failure. And of course, combine analysis, large vessels with tensiomet angiography not invasive method with the determination of augmentation indexes. And all in other vessels, including the more little vessels, it is tissue metalloproteinase index. The same direction rise indexes. The same process they describe. That is why it is interesting for me as for researcher, of course, to work with these indexes. And next, please. Changes in hematopoietic system and feature of therapy. Very short, I described in one slide that hemopathological changes present in a low platelets. Serum in some group was different low, but in some group higher, totally little higher, but a lot of patients with a low serum iron was revealed too, as a marker of bone marrow injury. And also, dear colleagues, medical therapy, what I reveal, that a large proportion of patients with elevated blood pressure receive angiotensin convertive enzyme inhibitors, angiotensin receptor antagonists, as well as ART drugs with protease inhibitors and nucleoside reserve transcriptase inhibitors, HIV special treatment drugs. And of course, possible to cooperate these data that this group of medications can be some trigger of arterial hypertension. I say about ART drugs, not about RC inhibitors, of course. That ART drugs for these two groups may be a reason of some more higher level, maybe in few millimeters of it, but it may be as a reason because I got quite clear different enough statistic analysis. Conclusion and prospects of clinical practice. Regarding this, my work presents new morphotypes of patient, HIV patient with chronic heart failure and elevated BP. It is a unique pattern of myocardial, renal, and vascular involvement with a specific bone marrow changes. And all these patients need for comprehensive monitoring, regular monitoring of blood pressure, vascular stiffness, and fibrosis marker. It is important for timely treatment. Impact of therapy, necessary control too. BP correction and optimization of antiretrovirus therapy may reduce cardiovascular risks and improve patient quality of life. That is why, if present rise of blood pressure in patients with HIV who taking antiretrovirus therapy, very important to analyze possible drug interactions and side effects and not prescribe this kind of drugs which can raise the BP level for this group of patients. It is very important. In my conclusion, I want to say that the disease, due to high lymphotrophicity of HIV, has a complex pathogenesis involving damage to the human immune system and topicity to inflammatory alteration of other system and target organs. These are primarily the heart, blood vessels, kidneys, and medullary hematopoiesis. There is multifactorial interrelated dysfunction of them, including simultaneous formation of immunodeficiency, chronic heart failure, arterial hypertension, anemia, thrombocytopenia, chronic kidney disease. The latter allows HIV disease of internal organs to be classified as a systemic disease by analogy with the system lupus erythematosus process, the same as many other systemic disease in HIV patient. It is a system multifactorial lesion of many organs and systems. On this point, let me say for you, thank you for your attention. On this picture, you can see one of the brand places of our Perm region. It is a stone town, natural reserve place. I will come to Perm region. It is the most beautiful in the winter time. If somebody have questions, please ask.
Kindly invite me to the webinar, third international webinar. It's my kind to be here. I am Mihman Mamedov, Professor of Cardiology from National Medical Research Center for Therapy and Preventive Medicine in Moscow, Russian Federation. And my presentation about cardiovascular risk in patients with type 1 diabetes mellitus. I have not any conflict of interest. Is an independent presentation. When it comes to diabetes, it's primarily type 2 diabetes that is mean. In international, such as United States and European guidelines for the management of patients with diabetes and cardiovascular diseases, information on type 1 diabetes mellitus occupies one small chapter. According International Diabetes Federation, type 1 diabetes is a polygenic multifactorial disease based on immune-mediated or idiopathic destruction of pancreatic beta cells leading to absolute insulin deficiency. Also, I would like to present some slides about prevalence of type 1 diabetes mellitus in worldwide. In 2021, there were about 8.4 million people with type 1 diabetes worldwide. There are about 350,000 patients with type 1 diabetes in Russia. By comparison, type 2 diabetes affects 320 million adults worldwide. It's 40 times more than type 1 diabetes. And age aspects of the prevalence of type 1 diabetes mellitus is interesting too. More adults are diagnosed each year than children. Only 18% were under 20 years old. 64% are aged 20 and 59 years, and only 19% are aged 60 years and older. The average age at the diagnosis is 32 years. There was a perspective of increase in type 1 diabetes. By 2040, the total number of cases projected to increase to 17 millions. It's about 80% increase compared to 2021. Also, I would like to demonstrate some basic aspects, the relation of type 1 diabetes mellitus and risk of cardiovascular disease. In people with type 1 diabetes, the risk of developing cardiovascular disease is 8 times higher than is the population without carbohydrate metabolism disorders. The pathophysiology of type 1 diabetes is characterized by rapid and early autoimmune destruction of pancreas beta cells, leading to hyperglycemia and the need for lifelong insulin replacement therapy. Hyperglycemia is one of the most important factors of the cardiovascular system. The high mortality from all cases in people with diabetes was at the glycemic hemoglobin level above 9%. Number of clinical studies have shown that carotid atherosclerosis in type 1 diabetes is associated with many pathologies and changes associated with a high risk of cardiovascular disease development. Is next risk factors: arterial hypertension, preeclampsia, retinopathy, insulin resistance, overweight, increased left ventricular mass, cerebral microbleeds, congenital impairment, inflammation and endothelial dysfunction. Also, I would like to present results of 2 registers. Register from Scotland and register from Sweden as with identical results. In register in Scotland, about 4,000 men and 3,500 women included, and in Sweden, national register, about 4,000 men and 4,000 women. At the age of 65 years and older, in 100 patients of case, there was a risk of developing cardiovascular disease more than 10% in the next 10 years. 5 years cardiovascular risk model from the Swedish National Register in patients with type 1 diabetes adjusted hazard ratio for fatal and non-fatal cardiovascular diseases were: for diabetes duration, 2.76. For patients age at cardiovascular disease onset, 1.47. For total cholesterol to high density lipoprotein cholesterol ratio, 1.26. For glycated hemoglobin, 1.19. For tobacco smoking, 1.76. For macroalbuminuria, 1.52. For previous cardiovascular diseases, 3.51. Also, Swedish, according to the results of Swedish National Registry, which include population 27,000 people with the type 1 diabetes and 135,000 people from the control group without diabetes. Duration of the observation was 10 years. During the observation period, 960 people with type 1 diabetes and 1,500 people from the control group died. The risk coefficients for individuals who developed type 1 diabetes at the age of 26-30 years were calculated, which in total amounted to 2.80, of which for mortality from all causes 3.60, Cardiovascular mortality 2.70. For non-cardiovascular mortality 3.85. Separately calculated the events for cardiovascular disease 60 for ischemic heart disease, 5.77 for acute myocardial infarction, 2.22 for stroke, 1 point for heart failure, and 1.18 for atrial fibrillation. Cardiovascular risk model for individuals with type 1 diabetes is possible too. Developers is experts from the Steno Diabetes Center in Denmark. The model was created based on data from 5,000 adult patients with type 1 diabetes. Observation period from 2001 to 2013. The final cardiovascular prediction model was tested on other population of 2,120 patients with type 1 diabetes. During the median follow-up of 8.6 years, about 18.4% patients developed cardiovascular disease, every fifth case. In the epidemiology of diabetic complication, ADC prospective cohort study conducted in Pittsburgh, United States, patients with type 1 diabetes aged 27 years with child onset, age less than 18 years, and average diabetes duration of 19 years. Association of cardiovascular events with risk factors. Major atherosclerotic cardiovascular events were associated with the duration of diabetes, albumin excretion rate, basal and systolic blood pressure, smoking, and mean glycated hemoglobin value. Also, it is very important the glycemic control and influence the glycemic control to cardiovascular outcomes in type 1 diabetes mellitus. According to data from the diabetic control complications and epidemiology diabetes intervention and complications, DCCT-ADIC study, good glycemic control has a beneficial effect on cardiovascular events in patients with type 1 diabetes. Adjusted for age, high glycated hemoglobin levels over 29 years of follow-up were associated with increasing risk of death from cardiovascular disease. Risk level is 5.20. Acute myocardial infarction risk level is 4.98. Stroke risk level is 3. Congestive heart failure risk level is 4.8. Transcatheter coronary angioplasty coronary artery bypass risk level is 5.40. Angina pectoris risk level is 4.75, but not with a silent myocardial infarction is not defines its risk level. Also, diabetes, good diabetes control led to reduce the risk. This the same study, DCCT-ADIC study from Pittsburgh. They compared this conventional therapy with intensive treatment, reduce the risk and cardiovascular events by 51%, risk of non-fatal myocardial infarction, stroke, or death from cardiovascular disease by 34%. In the DCCT-ADIC study, high glycated hemoglobin levels were strongly associated with the age and hypertension in relation to cardiovascular risk. Some data about lipid disorders and type 1 diabetes mellitus. In patients with type 1 diabetes, lipid and lipoprotein levels are often with normal limited. LDL cholesterol is significant predictor of cardiovascular mortality in patients with a type 1 diabetes, especially with the early onset of type 1 diabetes, with diabetes duration more than 20 years. According to a Korean study, statin therapy during a mean follow-up period of 9 years in 931 patients with type 1 diabetes was associated with a reduced risk of ischemic stroke, myocardial infarction. In young people with type 1 diabetes, PCSK9 levels are increased, and PCSK9 inhibitors reduce LDL cholesterol level by about 48% compared with placebo in patients with type 1 diabetes. And to my conclusion, type 1 diabetes is associated with high mortality than the general population from cardiovascular disease. Cardiovascular disease is the main cause of the mortality, but the underlying mechanisms are poorly understood. Lifestyle invitations and optical glycemic control without significant hypoglycemia are mandatory to reduce cardiovascular disease in patients with type 1 diabetes. Altered hyperglycemia plays an important role. The risk of cardiovascular disease remains high even with well-controlled patients with type 1 diabetes, indicating that other cardiovascular risk factors may be involved. It's a need complexly correction. What are the prospects for studying the relation between type 1 diabetes and cardiovascular disease? Further studies are needed to elucidate the factors involved in the premature development of cardiovascular disease in patients with type 1 diabetes to better predict and stratify of cardiovascular risk, as well as to clarify the age at which treatment with modern cardiovascular drugs should be initiated in young patients with type 1 diabetes. Potential targets for the new therapeutic approach to prevent the development and progression of subclinical atherosclerosis in patients with the type 1 diabetes need to be identified in future. In Russia, a clinical study has been initiated with under our team to identify characteristics of risk factors in individuals with type 1 and type 2 diabetes. Doctors from 15 cities of the Russian Federation are participants in these projects. The total number of patients is 800 people, men and women. Of the 300 patients with type 1 diabetes and 500 patients with type 2 diabetes. The following are being studies: features of cardiovascular disease, 16 biological and behavioral risk factors, assessments of glycemic control and correction of other risk factors. Also, in the last year, we published the review article about risk of cardiovascular complications in patients with type 1 diabetes mellitus, focus on dyslipidemia and hyperglycemia. You can read electron version in the International Heart and Vascular Diseases Journal, volume 12. Number 44. This is the December 2024. And thank you for attention. Also, I would like to thank organizers for kindly inviting me to the important.
Martini, a fourth-year medical student at Sulaiman Al-Rajhi University, Saudi Arabia. It is an honor to be here among the leading experts, you people in the field. And I really appreciate the invitation to present our work that is titled A Systematic Review of the Shifty Paradigm in Myocardial Regeneration, Advancing Living Biodrugs, Mesenchymal Stem Cells, Derivative as Biologics. This work is under the supervision of Professor Khawaja Hassan Haidar, Head of Research Department in Sulaiman Al-Rajhi University. So let's get right into it. Ever since the inception of the Paracran hypothesis that the repairability and regenerative effect of stem cells are primarily due to their paracrine secretion of the transplanted stem cells, not the cells themselves. So a few examples just for those cells like mesenchymal stem cells, wart and jelly mesenchymal stem cells, and umbilical cord mesenchymal stem cells. And there has been a significant advancement in harnessing the therapeutic potential of those stem cells in cardiac regenerative medicine. But today, we will talk about the advancement that have been done in the cell-free therapy based, the paracrine secretions, basically, beyond just these stem cells. Now, the family of cell-free therapy molecule is not very well categorized, but they branch off mainly two families based on their biological criteria. So let me see. Okay. So based on the biogenesis criteria, secretome, aka condition, which they are bioactive cellular secretion, immunomodulator substance, and also exosome that includes plasma membrane derived vesicles like ectosomes and macrovesicles. So in here, in this figure, you can see we constructed this figure in BioRender to just give you an easier illustration and visualize the molecular structure better with insight of clinical applications. So such, we can see in here soluble factors secretome, they are subcategorized into 6 subgroups. We have the cytokines, growth factors, enzyme, chemokinase, hormones, and extracellular matrix proteins, and also there are others. And their applications in ischemic injuries, wound healing, artificial skin biofabrication, COVID-19, acute respiratory distress syndrome, and other. Also, on the other side, we can see the exosomes. They are the cargo molecules, and an example for them, they contain mRNAs, miRNA, DNA fragments, and could be also injected with other drugs outside. So you can see all these soluble and insoluble in this figure. The aim of this study, it is a systematic evaluation and synthesis of preclinical and clinical evidence on the therapeutic efficacy and safety and mechanism of action of mesenchymal stem cell derived exosomes and secretomes, with a focus on their role as cell-free regenerative therapies for cardiac regeneration. All right, for the methodology, it is a systematic literature-based search through a number of databases, as you can see in here, and also the Prisma that we conducted after recording our 309 records were identified, and we screened through them, and eventually we got a total of 42 studies after excluding and inclusion criteria were applied. We used the assessment tool CIRCLI, ROB tool, for the Systematic Review Center for Laboratory Animal Experimentation Risk of Bias Assessment, and we are planning to use Cochrane once we have enough clinical trial to assess them. So, yes, see. Now, since we conducted the systematic review, our results were primarily qualitative and in nature, not the quantitative. And we used a lot of different cardiac parameter on the basis of which we collated and synthesized evidence for myocardial regeneration. And I will talk about those results and cardiac parameter in a second. Just a brief about the inclusion and exclusion criteria. Any study that used the exosome secretome from mesenchymal stem cells, studies that used any animals, models, small or large, and they recorded or reported change in cardiac parameters such as left ventricular ejection fraction, fraction shortness, stroke volume, infarct size, and myocardial thickness, and also angiogenesis. Exclusion, unfortunately, because of our lack of team or small team, studies that are not in English language were not retrievable for us, and they were excluded. Any other study design like case series, case reports, other than that, also excluded, and ones that did not report the outcomes. So for the results section, now the primary outcome of our study is were يعني left ventricular ejection fraction improvement and left ventricular fraction shortening, while the secondary outcome were the other stuff like infarct angiogenesis and left ventricular end diastolic volume, end systolic volume, myocardial thickness, and the report of inflammation and change in cardiac enzymes. So we have in here just a small for the poster presentation for the sake of the time. We included 4 studies, preclinical studies, just demonstrate. Those studies pointed out that exosome and secretome-based therapies have lifted the systolic performance of myocardial infarcted heart with left ventricular ejection fraction and fraction shortness improvement. Also, a decrease of scar volume and an increase in the thickness of the myocardium itself. Yes. In addition, we have a specific study in a porcine model where cardiosphere cell-derived exosome raised the left ventricular ejection fraction from 36% to 45%, a significant increase, while also decreasing the scar volume by third. And also another study used endothelial progenitor cells in small murine models, which with improvement of left ventricular ejection fraction and fraction shortness. There is other study that used a bioengineered off-the-shelf cardiac patch soaked with secretomes to drive a large gain in rats and pigs. So they did those large soaked patches with secretome and they put them on the heart itself. And they showed also an improve and increase viable myocardium by 30%. And another study that used human mesenchymal stem cell derived secretome in rats also showed an increase in vasculogenesis and the growth factors. So those are for the preclinical study. For clinical study, we went a little bit deep, but we couldn't find as much. But early clinical studies, such as there is a single-centered clinical study using coronary artery bypass grafting with exosome injection in Iran. This study enrolled a patient with severe systolic dysfunction, like ejection fraction less than 25%, and giving them umbilical cord mesenchymal stem cell exosome directly into the heart during the grafting surgery. And the primary outcome or endpoint is to assess the safety and function of the exosome injection. Moreover, in France, there is also another trial called the Secret Heart Failure Trial, where they are going to deliver 3 intravenous doses of cardiovascular progenitor cell-derived secretome to people with drug-refractory dilated cardiomyopathy. And the first participant that actually they did the procedure on him, he was a NIHA class 2 who showed a left ventricular ejection fraction improvement of 25 to 32 after the injection, and also a decrease in the NT-proBNP natriuretic peptide level at a 6-month follow-up interval. And also, he did not have any immunogenicity or adverse reactions. Unfortunately, there aren't many clinical trials about the cardiac regeneration using those approach. There are 4 other approach for skin wound healing and COVID and also Alzheimer's disease, but for cardiac regeneration is still a very new topic. And there are ongoing trials, and there is a huge potential for this field. All the study, you can find them in the reference section in here that I've talked about now. So for the now we can weigh the pros and cons of each therapy and compare them to what could potentially offer them superiority over stem cells. Secretome-based therapy employ a cell-secreted proteins that is enhancing tissue repair via receptor-mediated signaling. This approach shows wide range of application and such as wound healing, organ regeneration. On the other hand, exosome-based therapy utilize extracellular vesicle to transport specific molecules like mRNA, miRNA directly into the recipient cell. So it is a target-mediated medication. Potential medication, offering target molecular modification with minimal off-target effect. Exosome excel in delivering therapeutic agent across biological barrier, such as the blood-brain barrier, due to their immune evasion capabilities and their delivery mechanism nature. While both therapies use cellular products to influence the physiological process, they differ in signaling and delivering pathway. Such a delivering pathway, they could be injected or could be patches directly applied to the heart, and there are even studies about sprays to the pericardial or pericardium, and also inhaled. Depends on the application. A small just example for the comparison on what is the different, why we use cell-free therapy instead of cell-based therapy, because there are studies about cell-based therapy and the implanting mesenchymal stem cells directly to the heart. There are studies that already have done clinical trials on this. So, if a patient of acute myocardial infarction came, we are now going to treat him normally, either by the coronary artery bypass grafting or PCI, or depend on the etiology of that, is it STEMI or non-STEMI. For this example, if we wanted to use the stem cell approach to also enhance the treatment, we need to take an autologous biopsy from this patient bone marrow to culture those cells and modifying them a little bit, then redo the surgery where we are going to apply those cells to the heart again. This might take 2 weeks, 3 weeks, 4 weeks, it depends, and it is an invasive procedure as well. So there are high risk of failure, and also because of the prolonged treatment, we want to enhance those 2 weeks, 3 weeks. They are going to be a drawback for the stem cells. It is already the heart modulatory pathology have happened to this heart, so the stem cells won't show as much effect. However, in the other side, the cell-free therapy, those are already taken from stem cells already being cultured. They are ready on the shelf, so they have a very high potential. Also, they have a less risk of immune rejection, and an unfortunate thing about stem cells that they also could produce to tumor cells. So yes. In conclusion, we finally concluding that our finding, we've seen some promising result concerning the therapeutic efficacy and potential safety of their use in myocardial regeneration, where exosome offer target cargo delivery of different mRNA and secretome with their broad spectrum reparative factor that's been discussed. But there is still a lot of room for further research to investigate the pharmacokinetics and dynamics of these therapeutic interventions. Thank you. Any questions?
Thank you so much, Dr. Mohammed.
In the recent 10 years, with the clinical analysis of the 600 and 229 patients from our hospital, I'm from Taida International Cardiovascular Hospital, Tianjin University. Next. I cannot move the PPT.
Yeah, just a minute, doctor. Wait for a few minutes.
Can you move for me? Yes, next slide.
Sure, doctor.
Next one. Yes. The postoperative atrial fibrillation is a common complications of biomarkers associated with atrial fibrillation after coronary bypass surgery in the Journal of Thoracic Cardiovascular Surgery. Here is the mechanism for this. In this talk, I'm going to present it to our clinical data. Next. From this study, we can see from our patients, the incidence for postoperative for atrial fibrillation is around 28 to 30%, which is in accordance with the world data from other countries as well. And this study, we looked at the plasma metabolites that can be used as biomarkers for coronary artery bypass surgery and after operation, the atrial fibrillation. Next. Now here we did another study on the biomarkers and key pathways in atrial fibrillation associated with valve surgery. This morning I'm going to focus our study on the coronary artery bypass surgery. Next. Now, most recently we look at the protein biomarkers, and we did a literature review on the Nature Reviews for post-translational acylation of the proteins in cardiac hypertrophy. And we also focus on the coronary artery bypass surgery. Next. Here we presented to you a different protein biomarkers for post-translational protein modification in the heart failure patients, which we may be used in the future for coronary artery bypass as well. Next. And we also did another study to look at the post-translational protein modifications in the animal studies also from the patients with the atrial fibrillation. Next. Here we presented to you the protein structure changes after cardiac surgery. Look at I'm not going to go to details because it's very complicated and no time to present on this. But briefly, we look at the protein structures after cardiac surgery to look at the patients with atrial fibrillation with the protein substructure changes with a license modification. Here are the details, but I'm not going to go to details on this talk. Next. Here is the mechanism we discovered for how the post-operative atrial fibrillation happened with the structure changes of the protein. Next. In the third study, we look at the coronary artery bypass grafting vessels post-translational protein changes, which is in accordance with the protein structure changes in the cardiac surgery. And again, we don't have time to talk on the details, and we are going to focus on our clinical data of atrial fibrillation after coronary artery bypass surgery. Next. Next. Here is the protein changes. The next. Next. Okay, we pass this one. Next. Okay, the background for this talk, we're going to focus on the postoperative atrial fibrillation, which is a common complications after KBG. And our hypothesis is that preoperative risk factors may predict postoperative atrial fibrillation. So the aim for this study was to design to investigate the risk factors for pure AF, which is the postoperative atrial fibrillation after isolated KBG in the current era in more than 60,000 patients from our own hospital. Next. This is a retrospective study from March 2015 to January 2023. There were 6,229 patients fall into the category of this study with a isolated coronary artery bypass grafting without other surgery, and all the patients were first-time KBG. The preoperatively, all the patients were in sinus rhythm, and a univariate analysis between the patients with or without pure AF were recorded. And further, we did a multivariate and logistic regression analysis to look at the risk factors as the independent factors. Next. Pure AF was defined as a multiple episodes after atrial fibrillation lasting more than 30 seconds recorded by ECG monitor or wireless rhythm monitoring, and it began immediately after surgery or at any time before discharge, usually 7 days. Required treatment with anti-AF drugs. Usually we use amiodarone. Next. Here is the demographic and clinical data. The total number of the patients is over 6,000. There are 4,374 males and 1,855 female. This is the ratio with the age around 61, 7 years old. And in the pure AF, the patient 65, there is a P value. This is statistically significant. This is a BMI, hypertension, diabetes, peripheral vascular disease, and other demographic data. The main differences is the age, the hypertension, and the smoking history. Next. The methods was used, the surgical technique was all KBG procedures were conducted with a general and tracheal anesthesia. Surgeons could opt for either op or off-pump procedures depending on the individual cases. For off-pump coronary artery bypass surgery patients, pericardial stitches and heart stabilizer were used to expose the coronary arteries with intracoronary shunts for myocardial protection. For proximal anastomosis were carried out using a partial clamp technique. Next. Next, please. Here is some pictures for you. This is the internal mammary artery to LAD and use other arteries or veins for other vessels. Next. Now here's some pictures here to show you use the off-pump surgery technique as usual and performed everywhere in the world. Next. Yeah, sometimes we use radial arteries from the non-dominant arm. Here is the antispastic solutions to treat or prevent a spasm of the radial artery. Next. For on-pump surgery, we use Bachberg solution for cardioplegia. Here is the use for antegrade or retrograde, both together used for on-pump surgery. Next. For antispastic treatment, here is the study I did in 1993 to treat the mammary artery distal and spasm. Next. Now, we continuously publish some papers on circulation and other surgically related journals to look at the methods for the details of on-pump and off-pump surgery. Here are some examples for antispastic methods we used for KBG, usually on-pump surgery, but also can be used for off-pump surgery. Next. Now here for our classifications for arterial grafts, we usually use type 1, which is internal mammary artery for LAD, sometimes use type 3 radial artery for other vessels. Next. Now here is we use radial artery conduit for coronary bypass surgery, use our classification and our antispastic solutions. Next. We developed some solutions for antispastic use during KBG, which is called my name solution. This is #1 solution. Use verapamil calcium antagonists plus nitroglycerin. Next. Now here's some citations for our antispastic solution used during this period of surgery. Next. This is #1 solution with the verapamil, as I just mentioned. Next. Now, it is used, the solution for antispastic used, you can see that there is a spasm of the internal mammary artery before use of the solution. The solution was used through cardiac catheter to inject it into the coronary artery and the grafts. This is the internal mammary artery, and relieve the patient survived. Next. Next. Now here are some studies we did on these methods. Next. Now we developed the second solution, which used nicardipine and nitroglycerin, which is also used clinically now. Next. Because of the revolution of the calcium antagonists and antispastic solutions and drugs, we developed the third solution, which is antispastic solution for fasudil plus nitroglycerin as a cocktail solution, which now we are doing clinical trial. Next. Okay, now I'm going to present to you the very brief results. The incidence of the POAF in this group, more than 6,000 patients, is about 30%, which is in accordance with the reports for everywhere else in the world. Univariate analysis demonstrated age, hypertension, smoking, cardiopulmonary bypass time, and ejection fraction as the univariate factors for predicting the POAF. Next. Further, we did a multivariate logistic regression analysis to look at the interdependent risk factors. We found that 2 factors are independent. One is old age. The odds ratio is 1.062 with a p-value very high, significant. And the other factor is a low ejection fraction with OR 0.98, p-value 0.008. This shows that the old age and the low ejection fraction are both independent risk factors to predict postoperative atrial fibrillation after isolated coronary artery bypass grafting. Next. Now here we show you the details of the results. Probably we don't need to talk too much about this, but you can see very clearly the age and CPP, the low ejection fraction. These 2 are significant independent risk factors. Next. Okay, here we show you the age, which is in accordance with the incidence of a postoperative atrial fibrillation. I'm going to show you some figures next to predict this. And the second factor is low ejection fraction. And probably the next figure may tell you more details. Next. Oh, here. This is the picture. We show you the figure for the age. You can see at a higher age, more than 675 years old, the incidence is nearly 50% for postoperative atrial fibrillation. But in young patients, less than 45 is a very low incidence. So this tells you there is a very close correlation between the old age and the incidence of a postoperative atrial fibrillation. And the most patients are in this group between 61 to 65 years old. You can see the incidence is around 30 to 40%, which is very dominant in the whole group. Next. The second figure shows you the low ejection fraction is correlated to the incidence of postoperative atrial fibrillation. You can see when the ejection fraction lower than 50%, the incidence is almost 70%. But if the ejection fraction is more than 65%, the incidence is much lower. This tells you with the low ejection fraction before operation at high risk, this patient's incidence of postoperative atrial fibrillation is much higher than normal ejection fraction. Next. From this study, we can conclude that in the current era, after 2015, which is the most recently 10 years, after isolated coronary artery bypass surgery, there is still quite high incidence of postoperative atrial fibrillation with about 30% incidence in this group of the patients. The main risk factors correlating to postoperative atrial fibrillation including age, hypertension, smoking, long CPP time, and low ejection fraction. But among these factors, multivariate analysis identified old age and low ejection fraction as the independent risk factors associated with POAF. Therefore, our main conclusion is that particular care should be taken in the perioperative period for these patients in the prevention of POAF. Next. These studies were supported by our grants from National Natural Science Foundation of China and other grants. Next. Here is the end of my presentations. Thank you very much. This is my research team. Thank you for listening.
Thank you so much for your excellent presentation, Dr. Gui. Are there any queries?
Thank you.
Really fine your bag, and I'll be and then my co-author is Dr. Oga, and I will be presenting on the title from blood to heart, advancing cardiovascular research through hematological insights. The abstract: cardiovascular disease remains one of the leading causes of mortality and morbidity globally, while advances in cardiology have predominantly focused on the heart and vasculature. Growing evidence highlights the crucial role of hematological factors in the development and progression of cardiovascular disease. Blood components such as platelets, red blood cells, white blood cells, and plasma proteins significantly influence vascular health, thrombosis, and inflammation, which are the key factors in cardiovascular pathology. So this paper tries to explore the complex interplay between hematological factors and cardiovascular disease. So highlighting thrombosis, blood coagulation, and immune response as a critical contributor to disease progression. So recent studies have also shed light on the pivotal role of a disease platelets in thrombus formation and the development of atherosclerosis. So simply, this presentation is trying to highlight the need for collaboration, for networking, for integration of hematological aspects into the monitoring, diagnosis, and the management of cardiovascular disease. The next slide. Cardiovascular disease continues to be, as I stated before, as a leading cause of high mortality worldwide, accounting for approximately 17.9 million deaths annually, representing nearly 32% of global deaths, which means a lot of patients in the society die as a result of cardiovascular disease, and there is nothing like age limitation to that. It happens to the young, it happens to the middle, it happens to the adult, especially the aging patients or patients in the society. And of course, I'm sure that a lot of you as clinicians, doctors that are listening to me, there are a lot of stress associated with the profession, with the work. And then, of course, there is increased chances of cardiovascular disease, and which means it is very important to explore other ways of navigating and, of course, coming out with a better ways of managing our health. So as a multifactorial condition, cardiovascular disease includes a wide range of disorders such as coronary artery disease, heart failure, and stroke, which are characterized by complex interactions between various cellular and molecular mechanisms. Traditionally, research focus on the heart, blood vessels, and associated risk factors like hypertension, hyperlipidemia, and diabetes. But however, there are emerging concern or evidence that emphasize the critical role that hematological factors comprising the blood components such as the platelets, the red blood cells, the leukocytes, and the plasma protein can play in the development and progression of the cardiovascular disease. The next slide. So hematology, which we know involves a study of blood, both in health and in disease, has provided a valuable insight into the underlying mechanisms that drive a cardiovascular disease. And as I have mentioned some components, of course, we have the cellular and the acellular components of the blood, and all of them are involved as triggers to the contributory factors or risk factors, or as well in maintaining a balance or health for the heart, which is the center, the engine of the body. The role of platelets in cardiovascular disease has been well established. In healthy individuals, platelets are crucial for blood clotting and tissue repair. But of course, platelet-rich thrombi form primarily in response to endothelial tissue or injury, which often occurs as a result of atherosclerosis, hypertension, or other vascular insults. So as platelets adhere to injure the vascular endothelium, they release pro-thrombotic factors, which now amplify clotting or coagulation cascade. And of course, in this case, a vicious cycle will be activated, and then thrombi, which is the most important coagulation enzyme, will now continue to be produced, and then there will be a consumption of other components of blood, even leading to anemia and other complications, and even the anemia will also compound the case of cardiovascular disease, and then of course also forming some thrombi that may now lodge into vital organs, including the heart, and of course causing a myocardial infarction and other, maybe stroke and hypertension, and so many other heart-related problems. The next. So another important aspect of cardiovascular disease or relation to the blood or hematology is the coagulation system. As I have said, of course, a coagulation cascade involves a series of enzymes that, if not activated, they are regarded as zymogenes. And of course, there are critical factors that are very important here relating to the cardiovascular system or disease, involving fibrinogen factor 7 and thrombin. And as I've stated, thrombin is the most essential or most important enzymes, coagulation enzyme. If activated and not controlled, of course, thromboembolism and on maybe deep venous thrombosis may now start. And this can now cause occlusion and, of course, increasing the blood pressure, and as well as increasing causing inflammation, which is very critical in the cardiovascular disease. As in addition to platelet and coagulation factors, blood cells such as white cells and as can also, which are also derivative there in the blood, can also cause significant cardiovascular disease, of course, relating to the inflammatory processes, as I've said, maybe by activating the T cells, producing cytokines, of course, relating to the causing atherosclerosis and so many other plaques that are formed there as a result of some abnormal lipids, which can now cause occlusion to the flow of blood, increasing the blood pressures. And of course, today, you know that one of the things that kill a lot of patients globally is hypertension. It's related to work, it's related to gene, and so many other factors that should be explored in research, and then of course come out in a better way of improving life and then elongating the life of humanity. The next. The next. Next. So now we look at hematological mechanisms in cardiovascular disease, some areas that need to be explored even by researchers, clinicians, those in pharmaceutical companies. Of course, you have to consider the platelet activation and thrombosis. This part is very, very critical. Of course, in the context of cardiovascular disease, excessive platelet activation can lead to thrombosis, as I said, within the arteries, and then, of course, atherosclerotic plaques, which are caused maybe as a result of some deposition of lipids in the endothelial walls, which are composed of lipids, deposit inflammatory cells, and ADP, prothrombin factor, and thromboxane A2. So these factors promote further platelet aggregation, leading to formation of thrombus, which of course can cause serious problems to the cardiac system or cardiovascular system, including ischemic stroke, and then a cardiac infarction or heart stroke or heart attack. So platelet activation is critical. It is a critical step in the thrombotic process, and then understanding the mechanism or the molecular aspect of it offers an important perspective for the therapeutic opportunities. So antiplatelet therapies such as aspirin and P2Y12 inhibitors aim to block platelet aggregation and then prevent thrombus formation, which will now help to reduce the effect of this platelet activation and aggregation, causing a problem to the heart. And then these drugs are widely used in a patient with a cardiovascular disease. Next. Hello, next. Another aspect we need to consider is a coagulation and clotting factors. It is highly related to the first one, which I have explained, involving platelets. Of course, you know the link between a platelet coagulation system. Here, our major concern involves a fibrinogen, which forms a fibrin, which of course try to arrest the bleeding, and of course other factors like factor 7, factor 8 are very also so critical in this. And of course, when the studies have shown that fibrinogen level correlate with the extent of atherosclerotic plaque burden, which means you can use it as a marker, you can use it as a diagnostic marker for differential diagnosis, because of course, if you're able to pin down exact cause of the problem of a patient, I'm sure the cure, the treatment becomes becomes better. But of course, if you don't have a definitive diagnosis, you begin to query a lot of issues in a patient, because a lot of disease conditions mimic different signs and symptoms of the clinical manifestation. Next. Another aspect mechanism you need to consider here, from blood to heart in advancing research in cardiovascular diseases, involve inflammation and immune response. Inflammation, which I told you is a central component of cardiovascular disease and is intimately linked with hematological factors, particularly white blood cells, which induce the inflammation. So immune cells such as neutrophils, monocytes, and T cells are recruited to the site of endothelial injury or in the site of atherosclerotic plaque formation, where they contribute to vascular damage. So these cells release pro-inflammatory cytokines such as interleukin 6 and tumor necrosis factor. These factors are very, very important. These cytokines are very important for researchers to be explored. Of course, in the cases of cardiovascular disease, you will notice that these inflammatory cytokines are going to be elevated in case of the progression of cardiovascular disease, which you can now correlate with some other diagnostic measures or methods. So monocytes, which are also subset of white blood cells, are particularly important in the context of atherosclerosis. Upon migration to the vessel wall, monocyte differentiate into macrophages, which engulf oxidized low-density lipoprotein cholesterol, which is a hallmark of atherosclerotic plaque. This process contributes to form cell formation, which is a key feature of plaque progression, which of course can as well be used in diagnosis and then monitoring the progress and of course improvement of prognosis of patients with cardiovascular disease. Next. We have also considered endothelial functions. Of course, the endothelial function try to produce nitric oxide, which try to create a balance in the homeostatic form, because the blood in the body continue to circulate in fluid form. But of course, whereby there is a hypercoagulation, when there is a disarray, dysregulation, or activation of coagulation system, this process will be altered. And of course, you notice that thrombin will be highly secreted or produced, and then of course it's going to affect the system, the cardiac system, and then producing a thrombi, which will now cause a cardiac problem. And of course, inhibitors, something like protein C, protein S, thrombomodulin, will be affected. The next. We have hematological markers in cardiovascular system. Of course, I've mentioned some, but very important, we have to consider the biomarkers, something like solubilin P-selectin, thromboxane B2, and fibrinogen. As I told you, they are very important. And also vascular cell adhesive molecule VCAM1 and ADAMA, which is a full meaning is asymmetric dimethyl arginine. All these factors are very critical, which can give a definitive diagnosis as a biomarker for cardiovascular disease, which of course will be utilized. Of course, in this kind of research, there should be a need of collaboration between hematologists and then cardiologists and maybe internal medicine doctors. The next. Of course, this could also be utilized in personalized medicine and targeted therapy. Of course, because of the gene differences in the response to treatment, response to drug, of course, this will help to tailor the treatment maybe by the pharmaceutical companies who produce this drug, and then the clinicians who prescribe and offer the drug to the patient. Of course, to tailor it based on the specific need of the patient by going down to the level of characterizing the genes, knowing the gene differences of different individuals, because there are patients that respond fast. There are also patients that respond slowly. And of course, this will help, of course, in tailoring the need of the patient individually, not as a group, not as a community. Thank you. The next. Of course, I've mentioned these some of these factors. I've talked about the platelet activation markers involving soluble P-selectin, the fibrinogen, the platelet leukocyte aggregation, the thromboxane A2, the next, and then the CD40 ligand. The next. We have, of course, I've also talked about coagulation as very important in the progression and the process of the cardiovascular disease. I've talked about the fibrinogen, and of course, we also consider the activated factor 7, and then thrombin, antithrombin complex. And then another very critical marker there in the coagulation system is the dimers. And I'm sure as I'm talking, a lot of clinicians there who have been monitoring, who have been treating the patients with cardiovascular disease, of course, know this. And that is why even in the case, in the time of COVID-19, the D-dimer was among the markers that are used to monitor the recovery, the progression, and as well the recovery prognosis of the patient with such a problem. Next. We also consider some inflammatory markers, like when I was talking, I talked about the critical role played by some cytokines, particularly the interleukin-6, the tumor necrosis factor alpha, the C-reactive protein, and of course, you know that the C-reactive protein as an acute phase protein plays an elevated level of it have been linked to an increased risk of heart attack, stroke, and other atherosclerotic cardiovascular disease. So the CRP is often used in conjunction with other markers, such as fibrinogen and lipid levels, to assess a patient overall cardiovascular risk profile. And then even the interleukin-6 is also involved in the regulation of C-reactive protein production, and has also been shown to directly affect the endothelial function, promoting the development of atherosclerotic plaques. And the elevated level of interleukin-6 levels are associated with increased cardiovascular risk, particularly in individuals with chronic inflammatory disease like rheumatoid arthritis. And then, of course, tumor necrosis factor alpha promotes vascular inflammation, endothelial dysfunction, and then the formation of atherosclerotic plaques, making it an important marker for cardiovascular disease. So, of course, researchers, pharmacists, and all clinicians or health workers have to target some of these markers, control them. If you're able to regulate it, if you're able to put them under check, it means that the life, the well-being, the health of individuals will also be functioning well. Of course, you know, today, heart problem is one of the things that is a leading cause of high mortality and morbidity rate globally, and that is why you keep on having a hearing of cardiac transplant, heart transplant everywhere. You see it in the young people, among footballers, among doctors, among teachers, lecturers, professors, is everywhere. Of course, we need to monitor these markers, and if you're able to put them under control, of course, that means that the heart of a lot of patients will stay long and be highly active and then do the work effectively. The next. I've talked about the endothelial markers. Go ahead, the next. And then the other aspect that are emerging markers, biomarkers that we need to look at, maybe in the microRNAs, and then the lung at the side of lung coding areas, which are involved in the regulation of gene expression. Of course, you need to consider circulating endothelial progenitor cells, of course, in a short form known as APCs, which are involved in the vascular repair and regeneration. And then, of course, reduced level of APCs are associated with endothelial dysfunction and an increased risk of cardiovascular event, which means it has to be maintained to the its normal level to avoid reduction, which will affect the endothelial walls. Similarly, oxidized low density lipoprotein, as also LDL, is also a modified form of the LDL cholesterol, which is implicated in the development of atherosclerosis and has been proposed as a biomarker for early stage cardiovascular disease. So for clinicians involved in cardiology, of course, please, you have to monitor this. The moment you notice an increase in this level of modified LDL, of course, you should know that that patient, of course, has a cardiovascular disease. Of course, you need to correlate it with other clinical features or manifestations. The next. Therapeutic implications and advances in hematological biomarkers in cardiovascular disease. Of course, you have to target platelet activation, you have to regulate that point, and then, of course, you have to, from there, develop antiplatelet therapies, which will help to control, to regulate to monitor and manage the patient with cardiovascular system, and then newer therapies such as P2Y12 receptor antagonists like tigagrelor have also been developed to provide more potent and selective inhibitions of platelet aggregation, and then monoclonal antibodies and others that are also new that you need to explore. Yeah. Next. Of course, modulating coagulation pathways is also very important. Remember some of the factors I mentioned, like fibrinogen, factor 7, factor 8, and so many other activated factors. Thrombin, of course, you have to check all those points so that there should be no hypercoagulation that will induce formation of thrombin, which will cause a vicious cycle, and then even initiating a disseminated intravascular coagulation, which is going to cause a thrombi or thrombus, which will be lodged even in the heart and the blood vessels, and then causing occlusion, increasing the blood pressure, causing inflammations, and so many things that will begin to trigger the pathogenesis, the progression of cardiovascular disease, and then also forming a problem and also causing, you see some people dying suddenly. Maybe some people, they wake up in the morning, they couldn't check the temperature changes, and of course they will rush to their shower room, and of course before you know it, you hear the collapse because of the force of a lot of interactions, and then the link in these coagulation pathways. The next. So targeting inflammation and endothelial system. Remember, I told you that inflammation is critical, is central in the cardiovascular disease. And I've mentioned some biomarkers that you need to check, particularly the C-reactive protein, the interleukin-6, the tumor necrosis factor alpha, the canakinumab, and then interleukin-1 beta inhibitors, of course, and then the ADAMA, the VCAM1, and so many other biomarkers that you need to consider, and then target this inflammation, regulate it, checkmate it. Of course, in this case, there should be a balance between inflammatory cytokines and anti-inflammatory cytokines. And of course, when the ratio is towards the higher towards the inflammatory side, there is going to be much cardiovascular disease. The next. I've talked about a personalized medicine before, or approaches and emerging therapies. Next. Yeah, in conclusion, the intersection of hematology and cardiovascular research represents an exciting frontier in the fight against cardiovascular disease. By understanding the complex role of blood components such as platelets, endothelial cell clothing factors, researchers are uncovering new mechanisms that drive cardiovascular disease progression. So as advances in molecular biology, genetic profiling, and high output technologies continue to evolve, the potential to identify novel biomarkers and therapeutic targets will significantly improve the accuracy of diagnosis and then personalization of treatments. So the growing emphasis on precision medicine involved by hematological insights hold great promise for developing targeted therapies that can not only address the underlying cause, but also reduce the side effects by tailoring intervention to the individual needs, as I pointed out before. So the integration of artificial intelligence, as it is an evolving area now in every place, in every profession, and machine learning into cardiovascular research will further enhance our ability to predict, diagnose, and manage cardiovascular condition more effectively, easily, without much stress, with a better understanding of how blood-related factors contribute to cardiovascular pathology. New treatment strategies will be able to address these factors more directly. So my concern and your concern and the concern of a lot of health practitioners is to save life, to make life better, for people to maximize their potentials, for them to be productive to their immediate society, to the world. So I keep on encouraging you, please, may there be more exploration, more connection between the hematology and the cardiovascular, the cardiologists, for them to improve the well-being of the society, the individuals in the society. And I say thank you so much for listening to me. And then if there's any question, I am now open to receive the questions. Thank you.
Thank you so much for your insightful presentation, Doctor. I hope there is no questions for you.
A case of late postoperative AMA or left internal mammary in the area of LAD thrombosis and extensive anterior ST elevation MI.
Hello, Dr. Peter. Yeah, sorry for
Okay.
the interrupt. Could you please enable your slideshow mode?
Do you see the slides now?
Slideshow mode. Yeah, next to that.
Let's see.
Slide. Yeah.
Do you see now?
Yeah, it's fine. Perfect. You shall proceed.
Yeah. Left anterior descending artery, bypass via left internal mammary artery, is an arterial graft in the cardiac surgical treatment of multivessel ischemic heart disease, is the gold standard due to its long-term patency and durability compared to all other grafts. The diameter of the recipient vessel, the progression of atherosclerotic process, the use of antiplatelet therapy after bypass surgery, competitive blood flow from the native vessel, narrowing in a distal anastomosis, and dyslipidemia are among the causes of Lima graft stenosis. Acute Lima thrombosis causing acute coronary syndrome is rare. There are a few cases in the literature where we see acute Lima occlusion in the leg, inadequate antithrombotic management, or complications related to suboptimal surgical techniques, leading to dissection, hematoma, or constriction in the area of the graft. Here we report a case of probable thromboembolic event in the Lima graft after 8 years of aortic coronary bypass surgery causing acute anterior MI with ST elevation. The patient was 60 years old male, presenting with ECG and clinical and laboratory findings of extensive ST elevation anterior MI. He reported the onset of the typical angina pectoris at rest with onset approximately 1 hour prior to the present hospitalization. There was a lack of previous symptoms. The patient is with known multivessel coronary disease with 2 bypass grafts, Lima by LAD and vein graft by big marginal obtuse marginal branch 8 years ago. That was done in 2022. He is on therapy with ACE inhibitor, beta blocker, aspirin, statin, until now without subjective complaints of angina. He is with permanent atrial fibrillation, but he was without any oral anticoagulation therapy. Reported suboptimal blood pressure control, impaired glucose tolerance, and previous ischemic stroke 2019. The physical examination revealed patient in good general condition, without evidence of acute heart failure or pulmonary or peripheral congestion. Blood pressure was 150 to 100. Of course, irregular heart rate, muffled heart sounds. From the clinical laboratory tests, the common cholesterol levels were 7.3 millimole per liter. HDL was 1.1. The triglycerides were 1.7. And you see the common creatine phosphokinase fraction was elevated. Also, the MB fraction, the troponin was 0.12. In our laboratory, the upper limit is 0.04. The transthoracic echocardiographic examination demonstrated, you see, increased volumes. The diastolic volume was 145, telesystolic 85, sorry. Increased also length of the left atrium, and the ejection fraction was approximately, it was with reduced ejection fraction, less than 40. It was approximately 35-40 with apical hypo to akinesia. There are moderate insufficiencies in the mitral valve and also in the aortic valve. That is the coronary angiogram. You see the left stem is without stenosis. We know that there was a chronic occlusion of the LAD and also occlusion of the large marginal branch. And they were treated with internal mammaria by the bypassing the left descending artery, and also venous graft that was bypassing the large obtuse marginal branch. You see the left main is good. Also, there was a distal occlusion of the right coronary artery, but the surgeons, they didn't perform bypassing because the PD was patent. Before starting the selective angiographic examination, the shift doctor performed bolus infusion of GP2A, 2B platelet inhibitor. We are using tirofiban in our unit. You see the right coronary artery. And due to the ECG and the typical clinical picture and the biochemistry science, we thought that the problem was maybe in the area of the left mammaria. You see afterwards the scenes. That is the right coronary artery. And you see it was patent in the distal part, but there were some doubts about here in the proximal part that were some thrombotic particles, thrombus. You may see here that filling defect. Distal part were patent. Also, the patent was and the vein graft to the obtuse marginal branch. Also, in the progression of the procedure, the patient faced one ventricle tachycardia, and we performed cardiopulmonary resuscitation that was successful. And the lima was patent, no problem in the area of the left mammaria, no chronic occlusion of the left descending artery, non-occlusion of the also the marginal branch. And the patient, you see, was transferred to the cath lab. We made the hypothesis that this was likely a thromboembolic event in the lima graft area based on concomitant atrial fibrillation and the lack of anticoagulation therapy with apparently high CHA2DS2-VASc score. The patient received a loading dose of clopidogrel. After that, he was admitted to the ICU after the coronary angiogram. He was discharged from the hospital 5 days after the procedure without any signs of angina pectoris and signs of heart failure. Of course, we want to perform to check again the lima, but he refused. We want planned PCI procedure. Also, we planned him for ICD procedure, but again, he refused it. From the control cardiac biomarkers, you see the troponin levels reach the peak levels in our laboratory, more than 27 nanograms per milliliter. And also there were elevation in the other markers. From the echocardiography at discharge, the ejection fraction was 30. I'll show you also the ECG. You see definitely there was a ST elevation, and after that reduction of the ST elevation after the procedure with pathological Q waves. Of course, almost the whole wall of the left ventricle was done. He was with akinesia. And we thought maybe that was the problem. Here you see in the osteoproximal segment some uncertain signs for thrombosis. But the distal parts were patent. Represented the case of patient presenting with typical clinical laboratory ECG and echocardiography findings of ST elevation acute MI and previous bypass surgery, Lima by LAD and graft by circumflex artery performed 8 years ago before the present hospitalization. The use of left mammary artery as an arterial graft for LAD bypass is associated with significant short and long-term patency and a significantly better prognosis compared with the venous grafts. Lima graft has been shown to have 10-year patency in 90% of the cases. If a week after the surgical treatment there are no complications and if it is patent. Usually, Lima occlusion occurs in the early postoperative period and it is a result of complication related to the surgical intervention, dissection, hematoma, stenosis. Lima occlusion in the postoperative period is a very rare case and the exact pathophysiological mechanism is unclear. Thrombosis in situ, thromboembolic events, ulcerated plaque. In the present case, we described the patient with convincing ECG evidence of anterior MI with ST elevation, echographic signs of hypoakinesia in the left ventricle region, and previous bypass 8 years ago. From the performed angiographic examination, the Lima graft, which was expected to be infarct-related artery due to the above facts, proved to be patient with uncertain evidence of partial thrombosis in the osteoproximal segment. Perhaps this was due to aggressive pharmacotherapy and prior cardiopulmonary restitution. Post-procedure, ECG data were found. We found normalization of the ST segment, formation of pathological Q waves in all precordial leads, and ultrasound echocardiographic data for a drop in the ejection fraction of the left ventricle wall. Also, there were maximum levels of the troponin levels. The patient received optimal therapy for chronic heart failure according to the European guidelines, and anticoagulation therapy was added because of the high CHA2DS score. Follow-up examinations, the patient was without any complaints, but still with ECG data of atrial fibrillation and ejection fraction with apical hypoakinesia. You see, the thromboembolic was the most probable cause due to the presence of atrial fibrillation, high CHA2DS score, and the lack of anticoagulation therapy. There is one similar case that was reported. Also, Dubois and his colleagues described a septic embolism in the area of right internal mammary, but there was no evidence of sepsis in our patients. There were a few cases, maybe 5 or 6, with such mechanisms. Regardless of that type of mechanism, this case can teach us a lot. Despite excellent long-term patency, Lima can be susceptible to late occlusive thrombosis, which can have critical consequences. The early recognition of this possibility should direct the operator to directly cannulate the Lima rather than the native circulation and reduce the time to complete reperfusion. Aggressive pre- and post-procedural pharmacotherapy can also be a great benefit for optimal recognition and for the outcomes of the patients. Thank you very much. I want to thank you for the committee to invite me to this meeting. That was from me.
Thank you so much, Dr. Peter. It was an excellent presentation. Are there any questions from participant side? I hope there is no questions. Thank you so much, Doctor.
And unfortunately, they weren't able to attend the session. Okay. Next. So I'll be going through the outline, introduction, and then I'll give the details of the case presentation. We'll have a bit of a talk about what makes the case unique, and then we'll conclude. And then the references will be at the end, and I'll take any questions that you might have. Next, please. So as an introduction, cardiovascular disease is the leading cause of morbidity and mortality worldwide. And the most contributing disease entity to this is the ischemic heart disease, which is basically characterized by myocardial ischemia, as we all know. And the pathology of ischemic heart disease could be coronary or non-coronary causes, and I'll talk a bit more about this next. So as we all know, the most common type of coronary pathology is atherosclerotic coronary artery disease. Give me a second. How can I take this up? 1 second. And the other ones would be vascular. Please, just 1 second, please. Emeka, please come and help me take something out of my screen. I can't see my screen. Okay, so there are also vasomotor abnormalities, thrombosis and embolism, some congenital causes of coronary artery disease. Some people may have aneurysms that would lead to ischemic heart disease and intramural hematomas. Next, please. And the non-coronary causes are the ones that we call type 2 MIs, mostly from anemia, hypoxemia, hypertension, but also arrhythmias and myocardial hypertrophy or fibrosis could cause ischemic heart disease. Next, please. So the symptoms of coronary artery disease can be quite varied. The most common one, which we all know, will be chest pain or discomfort or back pain, epigastric pain, people presenting with indigestion, and particularly not persistent. And it's very important to recognize these signs for critical and timely intervention. Next, please. So for the patients presenting with chronic coronary syndrome, it's characterized by reversible ischemia. And some people might have an asymptomatic presentation where this is occurring and they don't actually have any symptoms. But the typical thing with it is that if they do have angina, these symptoms tend to be less than 10 minutes and would resolve. Next, please. And then the acute coronary syndrome, as we know, is unstable angina, NSTEMI, and STEMI. It could either be worsening of an already diagnosed angina or presentation of new angina symptoms, but it would typically happen at rest and last for more than 20 minutes. And when you have, the only time you give a diagnosis of STEMI is if there's persistent ST elevation. So if it's a transient ST elevation, it will still fall under NSTEMI. Next, please. And just a brief recap for the diagnosis of obstructive atherosclerotic CAD is where you have a reduction in greater than 50% of the luminal diameter of the coronary arteries. For the left main coronary artery, it would be a value for severity would be a value greater than 50, but for the rest, that's the right coronary artery, the left anterior descending, and the left circumflex, it would be greater than 70% to actually give a diagnosis of severe stenosis. Next, please. So I'm just going to describe a case of a patient which does not fit into this typical presentation of coronary artery disease. So this was a 56-year-old gentleman who's come in with a background of hypertension, dyslipidemia, and he had a history of premature atherosclerotic CAD diagnosed 14 years prior to presentation. And they had diagnosed this during a workup for exertional dyspnea, which he was having at the time. He underwent a PCI with the stent inserted into his left anterior descending artery. And after that, he had no symptoms prior to presentation. Next, please. He was on typical medications for patients with heart disease, ramipril, aspirin, rosuvastatin, a PPI, and an antacid. He had no drug allergies, but had a statin intolerance. He was an ex-smoker. He drank 10 to 20 units of alcohol, and he had no significant family history of coronary artery disease. Next, please. So he had presented to us with episodes of recurrent pre-syncope and syncope. He had had 3 witnessed syncopal episodes within 1 hour. And he also gave a history of 3 pre-syncopal episodes that had happened in the preceding 6 months. So we admitted him for cardiac monitoring. Next, please. So on further questioning, he gave a history of a one-year history of a persistent left-sided neck and shoulder pain, which coincided with the time when he had a road traffic accident. This pain he described was 10 out of 10. It was associated with pre-syncopal symptoms like dizziness, nausea, visual changes. And he particularly said that it was not related to physical exertion. And this was a patient that was very active, was doing a lot of mountain climbing, and never got these symptoms with climbing or any form of chest pain. The diagnosis from the GP was that of a musculoskeletal pain, which they attributed to his previous road traffic accident. Next, please. So in the GP, which is at his primary care center, they had done a cervical x-ray, which was normal. They had given him some analgesia, which wasn't helping the pain. So they had to refer him for physiotherapy, and he was waiting for a chiropractor appointment. This is to show how severe this pain was. Next, please. On admission, he had a slightly elevated blood pressure of 150 out of over 105. He was slightly bradycardic. His BMI was slightly overweight, 26.5, but the rest of his clinical examination was normal. Next, please. So on investigation, he had the full blood count. He had renal functions. His troponin I was normal. His renal function and liver function were all fine. His ECG showed sinus bradycardia with the borderline first-degree AV block, and he had no acute ischemic changes, no ST changes on the initial ECG. His chest X-ray was also normal. Next, please. And this was his ECG on presentation. It's just to show how normal it was. There was no ST elevation at all, and it was a sinus rhythm. Next, please. So on the 4th day of admission, while he was still having cardiac monitoring, he experienced a transient chest discomfort, which lasted for about 5 minutes and had come on while he was shaving. He described that the neck pain, which he had for about a year, was getting worse. And when he had an ECG done, it showed a transient inferior ST elevation. Next, please. And this is the ECG showing the ST elevation on the inferior leads 2, 3, and AVF with no reciprocal changes. Next, please. So immediately we activated the ST elevation MI pathway, which involved giving aspirin, clopidogrel, and we referred him for percutaneous coronary intervention. His CHOPS came back to up to 30, which was previously less than 4. And while we're awaiting transfer for PCI, because he wasn't at a PCI center, we repeated the ECG and it showed complete resolution of the ST elevation. Next, please. And this is the ECG he had done after the ST elevation ECG, which shows complete resolution of the changes. Next, please. So he eventually had the coronary angiogram, which showed severe proximal right coronary artery stenosis, and he had a moderate to severe mid-LAD stenosis. He had a staged PCI. The first PCI, he had insertion of 2 stents into his proximal right coronary artery. And 3 days later, he had an intravascular ultrasound study and then had 2 stents to his left anterior descending artery. He also had a normal echocardiogram after this. Next, please. So this is showing the coronary angiogram that he did, where the blue arrows are showing the severe proximal right coronary artery stenosis, and the right is showing just at the posterior descending artery is actually from the right coronary artery. That would show that he had the right dominant coronary circulation. And on the other side is showing the moderate to severe LAD stenosis about here. Okay, next, please. And then he had the stents inserted. So that's the blue arrows are showing where the stent has been inserted on the RCA and on the LCA, I mean the LAD on the B picture. Next, please. So he was discharged a day after the second PCI, and he had a 6-month follow-up telephone call to see how he was doing. The patient described resolution of the persistent neck and shoulder pain immediately after the first PCI session, which was the stent to the right coronary artery, showing that that pain he had for over a year was actually an anginal equivalent, which was persistent. Next, please. So just talk about, what makes this case so unique and how it doesn't fit into the typical presentation. We can all agree that given the fact that he had a transient ST elevation, that fits into the category of an end-STEMI, which he had. And actually, these patients with end-STEMI that have ST elevation, even though they are transient, are a high-risk group, and early invasive coronary angiogram within 24 hours is advised for these patients with end-STEMI. This patient had two-vessel disease. He had a severe proximal RCA stenosis, but also had a moderate to severe mid-LAD stenosis, and we feel that all his symptoms can be accounted by the severe proximal RCA stenosis. Given the fact that his PDA came from the right coronary artery, we can say that this patient had a right coronary dominance. So a brief recap of the anatomy of the RCA, just to show how this can account for all his symptoms. The RCA would usually supply the RA, the RV, and a huge part of the LV as well. It will also supply in 2/3 of patients the SA node, which would can give rise to conduction blocks. And in patients with in 70% of patients with a right coronary artery dominance, which he had, they would be the RCA would also supply the AV node, which can also cause conduction abnormalities. So this patient's persistent neck and shoulder pain has obviously been proven to be an anginal equivalent, given the fact that he had resolution, which did not reoccur after the RCA stent was inserted. Next, please. Okay. And the fact that this patient was having syncopal and pre-syncopal episodes can actually be explained by the SA and AV node dysfunction, which he had. He also presented with sinus bradycardia and a first-degree AV block, which we can actually attribute to his athletic fitness and say he has an increased vagal tone. But if we were able to do an ambulatory ECG monitoring and exercise testing, we can actually check if this bradycardia was variable and reproducible on exertion, and that would explain that he has ischemic nodal dysfunction as well. He also had the left ventricular inferior wall infarction, which was evident on the initial ECG with ST elevation, where it occurred on the inferior leads, and the fact that he also had a troponin rise and he had transient chest discomfort all fits into this. Next, please. We can all agree that this patient has a progressive unstable atherosclerotic CAD, but the question is this an ACS or is this a CCS? Because as we said earlier, ACSs would be more than 20 minutes, but it wouldn't give you a persistent pattern of a 1-year duration. And even for chronic, even though it lasts long, they tend to be remitting and on and off pain, which was not the case for this patient. And also say that his symptoms evolved over time because he had a 1-year history of unremitting neck and shoulder pain, then started having syncopal episodes, and eventually had chest pain, which led to the diagnosis of end-STEMI. So we presume that this patient most likely had an atypical unstable angina with an unusual protracted course, which was not remitting. Next, please. Going through his initial ECG, there was no evidence of Q waves. His initial TROPs were normal. That would go to say that he didn't have any evidence of infarction prior to his admission, even though he has been having this pain for quite a while, which is more in keeping with a CCS than an actual ACS. For things like if we had gone on to do an MRI, a cardiac MRI for him, then we would have actually checked if he had any evidence of infarction prior to admission. Next, please. So just a brief talk about CCS. From literature, typical CCS is characterized by a retrosternal chest pain or discomfort. It's precipitated by stress or it's relieved by rest. And patients that have 3 out of 3 will be classed as a typical CCS. Patients with 2 out of 3 would be classed as an atypical. But like our patients didn't have, he would have actually been classed as an atypical presentation. And 10 to 25% of suspected cases report a history consistent with typical angina. Next, please. So the fact that the patient had a lasting pain actually decreases the likelihood of CCS generally. And the symptoms tend to be episodic and transient because, as we said earlier, CCS is characterized by reversible myocardial ischemia. So it should be on and off. And that's even in patients that have atypical, less than typical angina, it tends not to be persistent. And that's the unique thing about this case. Next, please. So there's a question that we've asked in this case report. Could it be possible that this patient had multiple pathologies in this case? We're thinking he obviously had atherosclerosis, but did he also have the non-atherosclerotic CAD? Because he could have had epicardial vasospastic angina, he could have had coronary microvascular dysfunction, and these typically would not present the normal way with as normal angina from atherosclerotic CAD. And these patients tend to have the same risk factors as patients with atherosclerotic disease, which this patient had: hypertension, dyslipidemia, and smoking history. Next, please. But the fact that after his PCI, he didn't have these symptoms again makes it unlikely that he has other pathologies involved. But to actually characterize this, we would have to do an invasive coronary functional testing with acetylcholine, which we haven't done. We could also explain that this patient has an abnormal cardiac nociception and he has an exaggerated perception of cardiac pain, and that's why he's had this persistent pain. And abnormalities, he may have had abnormalities in his cardiac neural pathways. Next, please. So there's the European Society of Cardiology has recommended the RFCL model to check the likelihood of CAD in patients that are presenting with typical or atypical symptoms of angina. Next, please. So this diagram just goes on to show the model where you talk about the symptom score based on whether the patient has chest pain or dyspnea, talk about the risk factors of CAD, and then go on to check with the patient's age, what's the likelihood of actually this pain the patient experiencing being angina. If you can go next. Yes. So in our particular patient, he had one symptom score because he's described neck, jaw, shoulder pain, but it wasn't related, it wasn't aggravated or relieved by the typical things that would. And in terms of the risk factors next, he had 3 risk factors of coronary artery disease. He had next, smoking. Next. He had smoking, dyslipidemia, hypertension. And looking through this, if he was 57 years of age, next. And he had a 0 to 1 symptom score, tracing it down, and he's a man, it would mean that he's got a 7% likelihood. Now, for a patient next, please, a patient with a 7% likelihood of CAD, next. If this model was used by the GP, that's at the primary care center, he would have fallen into the category of people with low to moderate risk of CCS, and they would have gotten a CT coronary angiogram for him, which would have shown the severe RCA stenosis. For patients that have very high likelihood, you go on to do an invasive coronary angiogram, or for people with moderate or high risk factors or likelihood would have functional imaging. And for patients, if he had a very low risk of CCS, then it would have been okay to defer further testing. But obviously the GP didn't use this model, and that's probably why this angina was missed. Next, please. So this is just explaining what we've talked about. But actually, the reason why this diagnosis was missed was probably because, one, there was no exacerbation with exercise, even though this patient was a very active and fit patient and was mountain climbing, and this pain was not related to exercise. Two, the fact that it was very chronic, angina will typically persist with remitting pain on and off, and this patient had a 1-year history of chronic pain. And the fact that this coincided with him having a road traffic accident was another reason why this was missed, as it was attributed to a musculoskeletal pain from the road traffic accident. Next, please. And then we're talking about the variation. He's had 14 years ago, he was diagnosed with CAD because he was having dyspnea on exertion. Then he had a 1-year history of chronic left and shoulder pain, left-sided neck and shoulder pain. And then he had chest discomfort that's heralded at discovery of the NSTEMI. So that shows that even though he's had CAD, it has actually changed, symptoms have changed, and that means that patients need to be reassessed intermittently for their symptoms. Next, please. So this patient, generally in literature, obstructive CAD presenting with persistent angina is very rare. And the fact that the patient says, because some people might argue, was this pain actually present all the time, or was it just the patient not giving an accurate history? But actually the fact that he described sleep disturbance during this pain, and the fact that he was referred to the physiotherapist and even to a chiropractor would show that even the GP was concerned that this pain was present all the time. Next, please. So in conclusion, angina or its equivalents unusually can be chronic and persistent, as highlighted by this case. The symptomatology of obstructive CAD may also vary over time, so we need to reassess these patients. And clinician awareness of atypical CAD is very important so that patients with ACS and CCS will not be missed. And reassessment of pain, initially thought to be non-anginal, if the patient is not responding to treatments, like this patient wasn't responding to analgesia, physiotherapy, should prompt reassessment by the clinician. Potentially revising, we recommend potentially revising CCS diagnostic guidelines to better account for atypical presentations such as this. Next, please. Next. And these are the references used for the case report. Next. Next. Okay, and that's the QR code to go to the full article on PubMed. Thank you very much. If you have any questions, I'm happy to take the questions.
Thank you so much, Dr. Amando. That was an excellent presentation. I hope there is no questions for you. Thank you so much.
Thank you.
Efficacy of cryopreserved mesenchymal stem cells and their viability as living biodrugs for myocardial repair. To start with, mesenchymal stem cells have reached the advanced phases of clinical assessment for cardiovascular applications. However, the lack of ready-to-use availability remains a hurdle in their routine applications in the clinical settings. And long-term cell biobanking in liquid nitrogen could be an ideal solution for supplying mesenchymal stem cells as on off-the-shelf cell product. Still, its effectiveness in the clinical applications remains fully uncertain. Our systematic review and meta-analysis were conducted to ascertain the effectiveness of cryopreserved mesenchymal stem cells in the reported randomized controlled trials. And for the methodology, we have followed the preferred reporting items for systematic review and meta-analysis, or what we call PRISMA, and the guidelines from Cochrane handbook. For our eligibility criteria, we have included randomized controlled trials that evaluated the efficacy and safety of cryopreserved mesenchymal stem cells in patients with heart disease, which include acute coronary syndrome and heart failure. And our primary focus was to determine the cryopreserved MSCs in terms of left ventricular ejection fraction and major adverse cardiac events improvement. Also, we performed a subgroup analysis based on the origin of mesenchymal stem cells, which are basically two main sources, the umbilical cord and the bone marrow. And also, we performed a subgroup analysis based on the post-cell viability of mesenchymal stem cells. For statistical analysis, we calculated or we estimated the weighted mean differences and odds ratio for the changes in the estimated treatment effects. This on the right side here shows the studies or the report inclusion process. We have screened 4 databases, which were PubMed, Cochrane Library, MBIS, and clinicaltrials.gov. And after the application of our eligibility criteria and the abstract and full text screening, we have included 7 RCTs. So 7 RCTs involving a total of 285 patients were included. For the efficacy, we found that at 6 months of follow-up, cryopreserved mesenchymal stem cells derived from umbilical cord demonstrated a significant 3.53% improvement in left ventricular ejection fraction, while other cell types, including bone marrow-derived MSCs, did not establish a significant effect compared to the control group. When assessing the post-thaw viability, we found that MSCs with a post-thaw viability of over than 80% showed a significant 3.44 improvement in the left ventricular ejection fraction. However, MSCs with viabilities of less than 80% did not show any significant effect. This improvement or these improvements were observed at 6 months with as I mentioned, with umbilical cord and cells with post-thaw viability more than 80%. When analyzing the long-term effect of the treatment, specifically at 12 months of follow-up, we found that none of the cell types showed a significant left ventricular ejection fraction improvement compared to the control, and even cells with an 80% post-thaw viability did not show any significant effect. When assessing the mortality and major adverse cardiac events, we did not find any significant effect with cryopreserved mesenchymal stem cells on mortality and major adverse cardiac events. And that's take me to my conclusion. We concluded that treatment with cryopreserved mesenchymal stem cells significantly improved LVF in the short term, especially when using umbilical cord mesenchymal stem cells and post-thaw viability of over than 80%. For the limitations of our study, the small sample size significantly impacted our study results, as few trials are available with cryopreserved mesenchymal stem cells. Our findings emphasize the potential of cryopreserved mesenchymal stem cells as a viable option for heart failure patients, highlighting their promising in biobanking. And the barcode on the right side below, it's take you directly to our paper from PubMed. And that concludes my presentation. Thank you very much. Any questions, I will be happy to answer.
Thank you so much for your insightful presentation, Doctor. Any questions?
Thank you very much.
Yeah, thank you so much, Doctor. Moving on to the next presenter.
Cardiac surgeon, and here I would like to tell about giant aneurysm of the left atrium. The left atrial appendage aneurysm, or LAAA, is an uncommon and rare abnormality. LAAA is usually discovered incidentally in the third decade of life, but there are also cases in neonates and children. Since it first was described by Diamond on cardiac angiography in 1960, about 170 such cases have been described in the literature to date. LAA arises from the congenital dysplasia, developmental weakness of muscular wall. If it goes undetected and the delayed in diagnosis, it can lead to catastrophic consequences. LAA can manifest fatal complications such as tachyarrhythmias, atrial flutter, thromboembolism, outflow tract obstructions. Surgical interventions is indicated in symptomatic and most asymptomatic patients to prevent complications. Here we are presenting the diagnosis and successful surgical treatment of 90-year-old male patient with left atrial aneurysm. The patient was admitted to the hospital with complaints of rhythm disturbances and palpitations, dyspnea on physical exertion. ECG revealed atrial flutter with heart rate about 80 per minute. CT scan revealed aneurysmal enlargement is lying along the left contour of the left atrium, communicating with it by a wide orifice up to 18 or 2 centimeters in diameter. Size of this aneurysm was 105 and 85 and 87 millimeters. No other masses were detected in the lumen of aneurysm. On the echocardiography, left atrium mostly was within normal limits, antero-posterior dimensions 33 millimeters, left atrial volume was 37 milliliters, left ventricle and diastolic volume 55 millimeters, and systolic volume 40 milliliters. Ejection fraction of left ventricle was a little bit lower than normal limit, 47%, due to dysfunction of the walls of left ventricle, and we think because of rhythm disturbances. Left ventricle ejection volume was from 51 to 78 milliliters. Echocardiography also revealed a giant cavity, 110, 83 millimeters in dimensions, and 330 milliliters in volume, is adjacent to the anterolateral wall of the left ventricle, causing left ventricle compression and the effect of spontaneous blood contrasting, and also moderate tricuspid valve insufficiency. Here you can see on the echocardiography compression of the left ventricle, large aneurysm of the left atrium, and here is ostium about 2 centimeters. Here the whole picture of this aneurysm, and length more than 10 centimeters, and volume of aneurysm was 330 milliliters. Surgical treatment, aneurysm resection was performed through median sternotomy with cardiopulmonary bypass and blood cardioplegia. Ostium of aneurysm was closed by the xenopericardial patch by a cut. Here is you can see overall view of this aneurysm. After opening the pericardium, we saw large aneurysm of left atrium appendage. Here is left ventricle. After cross clamp of aorta, This aneurysm was empty, and you can see empty aneurysmal sac. Then aneurysm was clamped and ligated under visual control of the course of coronary arteries to avoid their damage and deformity. It was from outside. Resected aneurysmal sac, and the stump of the left atrium appendage was oversewn with double row suture. And from inside, the orifice of the left atrial appendage was closed by the patch of Biacat. Here is the patch, and here is the closure of the orifice. Several words about Biacat. It's our innovation. It's bovine pericardium, which produced by joint venture Farmland Belarus. We use it more than 20 years. And Biacat has sequential process of tissue treatment, mechanical cleaning, the process of decellularization and sterilization, and at the same time fixation with 5% of epoxide. We don't use glutarialdehyde because we consider that glutarialdehyde is poison for human. Storage solution contains 30% of DMCO and heparin. This patch doesn't need any additional rinsing, has very high degree of biological compatibility, very low level of biological degradation and calcification. That's why we can use it in a very young patient and even in newborns. So we can use it in our young patient. Additionally, during surgery, the patient underwent the cryoablation MACE 3 procedure in both atria and to restore sinus rhythm. Because of tricuspid valve insufficiency, the Vega valvuloplasty was performed. The sinus rhythm was restored on the operating table. The patient had uneventful postoperative clinical course and was discharged in good condition on the 10th day after the surgery. 2 years later, the patient is doing well, has sinus rhythm, no complaints. Orifice of the left atrial appendage is completely isolated, no any residual cavities, no stagnation zones, no signs of aneurysmal recurrence and patch calcification. So, delayed diagnosis and treatment of LAA can lead to fatal complications, emphasizing the importance of early detection and intervention. Accurate and prompt diagnosis is crucial for successful surgical outcomes in patients with left atrial appendage aneurysm. Thank you very much for your attention. This is all.